And the objectives are pretty much straightforward. So we're just going to define what are those pathologies included as spondyloarthropathies. We're going to list some of these pathologies. Unfortunately, we're not going to talk about all of them because there's a bunch of them and you're going to see. I'm just explain and show you imaging features of the main spondyloarthropathies we might find in our clinical basis. So spondyloarthropathies actually include a range of diseases or pathologies with similar clinical and radiological features. And those are spinal and pelvic involvement. Very often we can find asymmetric oligoarthritis. Inflammatory enthesopathy is often seen as well in those diseases, what we call enthesitis. And it's not rare to find extra-articular involvement as well, such as cutaneous and or ophthalmologic involvement in some of those diseases. Another particular point about the spondyloarthropathies is the genetic factor. Many of them express some histocompatibility antigens, and the most common of them is the HLA-B27 antigen. And just to tell you that if a person is tested positive for the HLA-B27 antigen, he or she has 20 times more risk to develop a spondyloarthropathy compared to a subject without such antigen. There's a possibility of transitory pathology, and this is a problem, especially for rheumatologists. When they're trying those subjects, very often we have a switch from one pathology to another, and this is very disturbing. We're going to show some examples, we're going to discuss about that a little bit. And the absence of serum rheumatoid factor in these subjects actually differentiate those from the seropositive inflammatory arthritis such as rheumatoid arthritis. So the pathologies included here, and you probably all know about those: ankylosing spondylitis, psoriatic arthritis as well, reactive arthritis, formerly called the Reiter's syndrome, enteropathic arthritis as well. And this is pretty much the four pathologies we're going to discuss in this lecture. Just to let you know that we have a bunch of undifferentiated spondyloarthritis as well that we cannot fit in any of the other spondyloarthropathies that we know. And often when we have very young subjects, less than 16 years of age, affected by spondyloarthropathies, we tend to call this a juvenile spondyloarthritis. Many rheumatologists now, especially in the European Society of Rheumatology, EULAR, they tend now to put the Cephal's syndrome as well as a spondyloarthropathy. So the basis of the pathology of all spondyloarthropathies, if you will, so the base is the pathology affecting the emphasis. And this is everywhere in the body, in the axial skeleton and in the appendicular skeleton as well. And I'm taking an example of the Achilles tendon to show you. So the emphasis itself, we're not seeing them. We're not seeing those fibers going within the bone, inserting within the bone on imaging, or even clinically, or even when operating, we don't see it. And the inflammation is going on exactly in this site. This is enthesitis. It starts here. And after we have this activation of inflammatory mediators, we're gonna have some spread of the inflammation on the surrounding tissues, and this includes osteitis, tendinitis, and periostitis as well as inflammation on the ligamental structures involved or surrounding. And as a healing process, as part of the healing process, we have production of bone by the form of ossification, and we're going to see that often in chronic stages of disease, and this is what we call the enthesophyte. This is what we see, and this is part of the healing process. You know that hyperostosis is a very common feature in spondyloarthropathies, and we're going to see that in some examples. Let's start with ankylosing spondylitis. So this affects especially young adults between 20 and 30 years of age, especially males, and this is the proportion comparing to females, especially Caucasian people. And up to 98% of subjects affected by ankylosing spondylitis, they're tested positive for the HLA-B27 antigen. And the typical clinical feature of such pathology is the inflammatory low back pain. This is different for the mechanical pain we see in osteoarthritis. Mechanical pain, often the pain is worse during the day. At the end of the day, after the subject or the patient, he did a lot of movement, a lot of exercising, a lot of work, so he starts developing a lot of pain at the end of the day. Inflammatory pain is different. This is more important at the very early, at the beginning of the day. And sometimes the patients, they even wake up in the night with pain, and as soon as they start moving, exercising, the pain goes away. It's better. So it's another pattern of pain compared to mechanical pain. So this affects especially the axial skeleton. I'm talking about the spine and the sacroiliac joints, compared to the appendicular skeleton, which are the upper and lower limbs. So usually we have this ascending involvement. This is not a rule, but it's often seen starting at the sacroiliac joints, so in the lower level of the axial skeleton, and then it goes to the thoracolumbar spine, and finally to the cervical spine. And at the end, of course, when we have a lot of ankylosis, the patient can have this skier position, bent like this, because he cannot move anymore. Everything is ankylosed, and we're going to see some examples of that. Asymmetric oligoarthritis can occur in ankylosing spondylitis, especially in the lower limbs. This is a feature that we see. Enthesopathies, of course, everywhere we can see enthesopathy in patients with ankylosing spondylitis. But predominantly we see in the Achilles tendon and the plantar fascia. And extra-articular involvement can occur as well, especially ophthalmologic and cardiac involvement. We're not going through details. I will focus on the MSK features, imaging features of the MSK system. I'm not going through in detail for the criteria. Each spondyloarthropathy, ankylosing spondylitis, psoriatic arthritis, enteropathic, and so on, they all have special criteria for diagnosis. I just put this slide for you to show you that imaging now, it's extremely important, and it was included as criteria for diagnosis of spondyloarthropathies, and in this case, ankylosing spondylitis. Before, only X-rays were considered, and now we have MRI features included as a criteria for diagnosis, for the diagnostic of spondyloarthropathies, and in this case, ankylosing spondylitis. So I'm going to show you some features of the axial involvement, which is the main involvement in ankylosing spondylitis, starting with the sacroiliac joint. Classically and described in the books, everyone can read that in radiology books, it's the bilateral and symmetric involvement of the sacroiliac joints. But this is why I say classic, because this is old. This was diagnosed with X-ray when the pathology was already advanced. So we could see involvement in both sacroiliac joints. Now with MRI, we can see that it's not really like that. So this is classic, but it's not necessarily the truth, especially in the early stages of disease, and I show you examples of that. So what we see on imaging, so we have an X-ray and a CT scan to show you, this is the same patient. One scan first X-ray, and then we perform CT. So we see subchondral sclerosis is a feature of sacroiliitis seen in ankylosing spondylitis. It can be anywhere, but classically we see sclerosis predominantly in the iliac aspect of the sacroiliac joints. We can see also erosions, and you see it's pointed by the arrows on X-rays and especially on CT, because we have high resolution in cross-sectional imaging. It's better to see erosions. Widening or narrowing of the joint. Such widening can be seen especially in the early stages of sacroiliitis, especially in the inferior aspect of the joint, where is the synovial part of the joint, and we can see some joint fluid in there, making the joint space wider than the rest of the joint. Sometimes such widening here is just showing some narrowing of the joint, and sometimes the widening we see, it's because of the erosions. So we have erosions, and we have the impression that the joint is wider. Blurring of the subchondral bone, actually we can see, especially this is provoked by very small erosions that we cannot depict alone, and ankylosis is not demonstrated in this example. We're going to see it later. So this is a case of a young man with ankylosing spondylitis. So he has a low back pain with an inflammatory rhythm, and we see here on the X-ray some changes on the inferior aspect of the sacroiliac joint, irregularity, some widening, some blurring, and some sclerosis. I think everyone can see that. And when we perform MRI, we see the extent, the real extent of pathology, with a lot of bone marrow edema patterns subchondraly, showing high inflammatory activation of the left sacroiliac joint. So this is left sacroiliitis, and this is a very early stage of disease. So be careful. In the early stages, this is not bilateral and symmetric. This might be unilateral, and when it's bilateral, can be asymmetric as well. So now the pattern changed a little bit with MRI. So we see an X-ray. We know there is bilateral sacroiliitis in this case, with blurring, erosions, subchondral sclerosis, predominantly in the iliac aspect of the joints, but we cannot tell about inflammation activity when looking X-ray. We cannot. We can only talk about inflammation activity when performing MRI or scintigraphy as well. But MRI, it's better because we have a nice anatomic overview of the joint, what scintigraphy usually doesn't give to us. So stir sequences is highly prescribed by rheumatologists, and this is even in the criteria I show you. They only put stir, they don't put T2 fat suppressed sequences or proton density fat suppressed sequence. I personally think it's the same, but we need studies to show that. So the stir showing the bone marrow edema pattern bilaterally, and see this case is not symmetrical at all. This is bilateral asymmetric sacroiliitis in a subject with ankylosing spondylitis. And you can see here as well the high signal intensity on stir within the joint, showing some joint fluid and showing some inflammation within the joint. And as well, the T1 fat suppressed gadolinium enhanced sequences can show us the inflammation activity. So you can see here some enhancement of the subchondral bone, showing inflammation features, and we can see here enhancement of the joint itself. So high signal intensity within the joint after gadolinium injection. So again, if you want to measure inflammation activity, go for MRI, is the best imaging method. X-ray will not tell you that. And of course, this is very important when we are following up the subjects before and after treatment. And this is an example of subject. He was diagnosed with ankylosing spondylitis. So initially he has this very important right sacroiliitis with a lot of bone marrow edema, high signal intensity within the joint, maybe some sclerosis or even some fat here. As the repairing process, we're gonna see fat subcontrally. The left side is pretty much okay in that coronal stir sequence. So after he was treated with tumor necrosis factor inhibitor, which we call as well the anti-TNF, you can see that this huge right sacroiliitis it's basically gone. We don't have a lot of inflammation anymore, but now we have small inflammation in the inferior aspect of the left sacroiliac joint at follow-up. And this is an example to show you the end stage. This is very easy to diagnose, but no one wants to diagnose the patient in that stage. This is very bad. This is a stage that all these drugs we know won't have any more effect on the natural history of disease. We want to diagnose those in the other slides I show you when we see the very early stages of inflammation. So this is ankylosis. We don't see the sacroiliac joints anymore, and you can see the MRI as well, areas of ankylosis, meaning fusion of the bone, so we cannot see very well the joint, the joint space itself. Okay, now moving to the spine. So how it's working, I told you the problem is within the emphasis, and this is everywhere. In the spine, it's just the same. It's the same problem. So here you see the annulus fibrosus in the disc. This is the intervertebral disc. Hope it's similar to an intervertebral disc. So this is the annulus fibrosus, and the anthesis we're not seeing as well. So here's the anthesis. So where the annulus fibrosus is inserting within the bone, in the anterior and posterior corns. So inflammation will happen here. So this is the enthesitis exactly at the site of the insertion of the annulus fibrosus in the anterior and posterior corners of the vertebral bodies. And this inflammation, of course, will spread, so we're gonna have osteitis. I'm not sure it's displaying well in here. Why this is black? Because on mine it's red. I'm not sure why this is happening, but this should be red, fellas, okay? I'm seeing red in my laptop, in the laptop. So we have some osteitis going on here, and that's what we call spondylitis. So spondylitis can be anterior, what is called Romanus lesions, or it can be also posterior. Some authors call this as well as Romanus lesions. So, but classically, this is the anterior spondylitis that is called Romanus lesions. So I show you some examples. X-ray sometimes is very difficult. What we can see, it's very subtle changes in the anterior corner. So you see, it's really mild sclerosis we can see in some anterior corners, but we cannot. This can be called unremarkable without any problem, normal X-ray. But we see the MRI, so T1 and T2 sequences. So we see those areas of low signal intensity on T1 and high signal intensity on T2 and stir, indicating inflammation in the anterior corners of the vertebral body. So this is active Romanus lesions. We have inflammation going on in the spine. On the other hand, when we have chronic or inactive Romanus lesions, this is the pattern that we'll find. So high signal intensity on T1, and on stir and T1 fat suppressant, we're going to suppress the signal. You can see the signal, these changes now have low signal after fat suppression. So this is fat. This is fat replacing the inflammation we see before, and this is part of the reparative process of spondylathropathy. So these are inactive Romanus lesions. On the X-ray, we can see already those very thin syndesmophytes, which we're going to talk about later, as well as large, wide ankylosis in the facet joints. So going back to our drawing, so now what we can see, yes, my red is not working. This should be red, okay? Well, what we see black should be red. So just to show that we can have as well inflammatory involvement of the intervertebral disc in such pathology. And this we call spondylodiscitis. because Anderson described that first, so we often call this Anderson spondylodiscitis or Anderson lesions. So just to show you some examples. So this is an example of an active or inflammatory Anderson spondylodiscitis. So you can see destruction of the intervertebral disc with high signal intensity and low signal intensity on T1, high signal intensity on T2, showing the edema pattern of the subchondral plate, what tells us that there is inflammation going on in this process. So this is active. I show you another example of the thoracolumbar spine to show you that in some levels we can have active lesions, and in other levels we can have chronic lesions. And that's the problem. Sometimes it's difficult to measure activation, inflammatory activation. It is difficult to measure inflammation when we're following up these subjects before and after treatment. So here are some levels where we see low signal intensity on T1 and high signal intensity on T2 and STIR with inflammatory enhancement after gadolinium. So those levels we have inflammatory activation. On the other hand, we have some levels that we see actually signal of fat with high signal intensity on T1 and T2 and no high signal intensity on STIR and no enhancement after gadolinium. So those are chronic or inactive Anderson lesions or chronic spondylodiscitis. And of course, after this inflammation is gone, as the part of the repair, repair process, we're gonna have some ossification going on surrounding the annulus fibrosus, what we call syndesmophytes. And this is a feature, this is a very important feature when evaluating, when assessing any exam from a patient with suspicion of spondyloarthropathy, not only ankylosing spondylitis. As well, what we can see is some remodeling of the anterior and posterior corns, and we're going to have this feature that we see often on every imaging method, which is the square vertebral bodies. And this is a very important feature as well. So I show you some examples of that. So here we can see in the early stage very mild changes in the anterior cornus, probably referring to Romanus lesions. And the square vertebral body we can see as well, but not a lot of endosophyte, syndesmophyte formation here. Here we can see some syndesmophyte formation in a very early stage. I think everyone can see here with the square vertebral bodies. Another later stage. Now, yes, we can see a very nice syndesmophyte anteriorly, just like here. And sometimes syndesmophytes can be large and irregular, like this one. This is less common with ankylosing spondylitis, but more common with other spondyloarthropathies, and I will show you some examples later. So here's to show the typical feature of a syndesmophyte seen on X-ray. This is very thin ossification about the external part of the external aspect of the annulus fibrosus. So here laterally, and here anteriorly and posteriorly. So a feature we're going to see often when imaging these patients with the syndesmophytes, we can see also extensive ankylosis in the posterior elements of the joint. Here the facet joints, a lot of ankylosis here. Some squaring of the vertebral bodies and syndesmophyte. This is what we call the bamboo spine. It's a typical feature of ankylosing spondylitis we can see. Just to show an example on CT, how we can see better, we can evaluate better and depict better those syndesmophytes anteriorly, posteriorly, and we can see as well extensive ankylosis in the posterior elements in the facet joints, as well as ossification occurring at the level of the interspinous and supraspinous ligaments in the posterior elements of the joint. So spondyloarthropathies represent a group of disease that is producing a lot of bone. It's producing bone. It's hyperostosis. So keep that in mind. can be helpful. Other synovial joints, of course, can be involved. So here the facet joints with ankylosis and hyperostosis. Here the costovertebral joint, the right one, with ankylosis and hyperostosis as well. But again, we don't want to diagnose ankylosing spondylitis in this stage. This is not a good stage to diagnose it. This is easy to diagnose, but it's not here. We want to depict the very subtle findings where when we start the treatment, we can change the natural history of disease. To show an involvement of other synovial joints in the spine, so the costovertebral joints, you can see inflammation all the way on the sagittal plane and the axial planes. All of those are T1 fat suppressive gadolinium sequences. And this is a potential complication that we have to be aware of, and this is very important. The spine in such subjects, especially in the late stage of disease, in chronic stage of disease, it's a very rigid spine. They cannot move a lot. The range of movement is very limited. And we can see that clinically with visual inspection. We don't have to imaging those patients to see that. So sometimes, without any important trauma, these subjects start to develop pain, another pain, unusual pain. And we do X-ray, we do any other imaging method. And we see, you can see here, extensive ankylosis with syndesmophytes. So it's a classic bamboo spine, the typical classic bamboo spine. But if we look closely in one of these levels, this level here, now it's easier because I have a spot, the level is there, it's the same level. Something's going on here, this is not normal. Especially that anteriorly, we don't see a continuity of the syndesmophyte here. There's a breakout, everyone could see that, okay? So this is an example of a transdiscal insufficiency fracture. Because it's a very rigid spine, so it's not moving anymore, so we don't apply load anymore to that vertebral bodies into that spine. So what we have at the end is osteopenia. It's very important osteopenia. So it's very common to have these transdiscal insufficiency fractures, and we have to look careful in those subjects, especially in the posterior elements. They can be highly involved in such transdiscal fracture. This is the same example I showed you, the X-ray. Now we perform the CT, and on CT we can see better an involvement of the posterior elements. And this is an emergency. This is very important. So we cannot overlook those fractures in these patients. So be careful with the posterior elements. And this is an example to show you again. This is a rigid spine, but it's a very fragile spine. It's really fragile. Huge osteopenia. This is a subject with ankylosing spondylitis. You can see here already something going on in the posterior element, probably a transdiscal fracture, and this subject was going to be intubated for an emergency purposes. And unfortunately, that's what happened with the subject. So this is a very low energy mechanism of trauma. It's a simple hyperextension just to intubate the subject, but because he had ankylosing spondylitis, a very fragile spine, that's what happened, unfortunately. Of course, MRI is useful to follow up not only the involvement in the sacroiliac joints, but also in the spine. So see, before treatment, very important anterior spondylitis in this case, and after anti-TNF, you can see it's gone in the follow-up. So very useful as well to monitor the spondylodiscitis, the Anderson lesions. So very important spondylodiscitis with high inflammatory activity at baseline, and after anti-TNF, you can see the inflammation is gone. So MRI is useful to monitor and to follow up these patients after treatment. What about the appendicular involvement? I will go through quickly for the appendicular. So ankylosing spondylitis can affect the upper and lower limbs, and classically is the calcaneum insertions of the Achilles tendon and the plantar fascia. Of course, on the X-ray we can see a lot of hyperostosis and antizophytes being produced, but we cannot measure the inflammation. with MRI, and this sequence T1 with gadolinium. You can do STIR or T2 fatty-suppressed sequences as well. You're gonna measure the inflammation. So huge osteitis, huge inflammation at the insertion of the plantar fascia. So it's plantar fasciitis going on here in a subject with AS. Doppler ultrasound may be useful as well when imaging peripheral structures. Especially here we have an example of calcaneal enthesitis in this patient with ankylosing spondylitis. So you see here inflammation depicted by the Doppler when performing ultrasound, and especially you can see the bone here, the cortex. There's a lot of bone production. This is hyperostosis. This we see often in spondyloarthritis. Another example to show you that enthesitis can occur everywhere in the body in these cases. So here is the deep plantar ligaments. You can see here in the hind foot, here in the sinus tarsi location, and here you can see at the proximal anthesis of the tibial tract. It can occur as well in the extremities, so you see here an example, and you can see some swelling of the soft tissues. This is the fourth toe, I believe, of the foot, and you can see here some periosteal reaction going on, with a lot of swelling of the soft tissues. And when we perform ultrasound, you can see here the periosteal reaction, it's periostitis, with soft tissue swelling, and the Doppler is showing us the inflammatory activity. So this is an example of dactylitis and periostitis seen in a subject with ankylosing spondylitis. But this is way more common in other spondyloarthropathies, and I'll show you that. And to finish, ankylosing spondylitis, another example, very mild hypertrophic change here in the medial malleolus of the tibia. We see the Doppler ultrasound. Inflammation going on, hyperostotic changes, and actually this was a case of enthesitis of the flexor retinaculum posteriorly. You can see the flexor retinaculum here thickened, and you can see the high inflammatory activity on the ultrasound Doppler performed. So let's go faster for other types of psoriatic spondyloarthropathies. So psoriatic arthritis involve adults between 30 and 50 years of age, and especially those with cutaneous psoriasis, and we're going to show examples of that. It's affecting males and females in the same proportion, and up to 30% of those subjects, they express the HLA-B27 antigen. And it's a problem. It's not a lot. So it's very difficult sometimes to perform such diagnosis. And it's affecting especially the appendicular skeleton and not the axial skeleton as in ankylosing spondylitis. So what's the report with psoriasis, which is the cutaneous manifestation of disease, and psoriatic arthritis? So just to know that 5 to 7% of patients with psoriasis, they develop arthritis. So this is a number that you should have in mind. This is very good. So in most of cases, up to 70%, the cutaneous involvement comes first, then the musculoskeletal involvement. So it makes much easier to perform the diagnosis. So you know the patient has psoriasis, and then he developed arthritis. So this is not a problem to diagnose psoriatic arthritis. This is not bad as well, because you have simultaneous cutaneous and articular involvement, and up to 15% of cases. So both appear in the same time, and this is easier. The problem is those 10 to 20%, where the articular involvement appears first. So you have arthritis, but you don't have psoriasis. And this is very, very difficult to diagnose the patients. HLA-B27 often will be negative, only up to 30% will be positive, and this is really, really disturbing for the rheumatologist to perform the diagnosis. So, classically, it's an oligo or monoarthritis, can be unilateral, and when it's bilateral, it's often asymmetric. And in 70% of the time, we're going to see pathology in the hands, fingers and hands. So the distal interphalangeal joints are often involved. We have a very particular formal presentation with the sausage digit, actually corresponding to psoriatic dactylitis, and we will show you some examples. Osteopenia may be absent, or when it's present, it's very mild, and I'm telling you that to differentiate from rheumatoid arthritis, where we see a lot of osteopenia involved. And this is a feature that's going to help us to make the diagnosis. It's hyperostosis. We have production of bone near the erosions. The problem is every time you see some arthritis in the hands with erosions and swelling, we're going to think about rheumatoid arthritis. But what rheumatoid arthritis doesn't have is this hyperostotic changes near the erosions, and I'm going to show you some examples. And ankylosis as well is a feature. Of course, we don't want to diagnose the patient at that stage, but when we see that, it's easier to make the diagnosis because we don't see that with rheumatoid arthritis. And the terminal digital tufts can be involved as well by acrosteolysis and hyperostotic changes, and we're going to show some examples. So here one example of psoriatic arthritis. So you can see we have some swelling of the soft tissues of those digits, and we can see here features of arthritis in both proximal and distal interphalangeal joints. So let's take a look closely of these features. So we can see erosions, marginal erosions and subchondral erosions. We can find that in rheumatoid arthritis as well. What we don't find very often in rheumatoid arthritis is the involvement of the distal phalangeal joint. This is not common in rheumatoid arthritis. Most common is metacarpophalangeal joints and proximal interphalangeal joints. And again, what we don't find in rheumatoid arthritis is this periarticular hyperostotic changes, which is sort of periosteal reaction, and especially when we see those near erosions. This is very typical of psoriatic arthritis, and we have to pay attention on such feature. And the terminal digital tufts can be also involved, especially in this case with hyperostotic changes, as you can see here. Okay, this is another finding. This is a non-specific finding. Acrosteolysis we may see in a bunch of diseases, but we can see as well in psoriatic arthritis. And this is another example of very important hyperostotic changes in the distal phalangeal bone, especially in the terminal digital tuft, as you can see here. Arthritis, of course, it's another feature, and periostitis, and again, hyperostosis is often seen in those patients. We don't see often, and you could see in this osteopenia, we don't see that. Or when we see, it's very mild osteopenia. Ultrasound may be useful to diagnose some subjects. So here an example where we can see lots of features. So we have tenosynovitis with fluid within the tendon sheath. Here you can see synovitis with joint fluid as well. You can see some erosions, marginal erosions, as well as hyperostotic changes. So ultrasound may be useful to evaluate all those features. Again, to show you features of very mild enthesophytes actually showing some hyperostotic changes involved. And in the pulp of the finger, we can see some inflammation as well, and ultrasound, Doppler ultrasound may be useful to detect such finding. I go through this example very quickly just to show the aspect of the sausage digit. It's a very typical feature of psoriatic arthritis. So we see some swelling of the soft tissues. And of course, we're going to see some other findings going on. The joints, the joints are not that bad when we see in that X-ray. But when we see the MRI of the same case, this is a case extract from the literature, we see a very important dactylitis. So this is inflammation in the deep and superficial soft tissues, and we see some features of arthritis as well in the interphalangeal joints. So this is a typical case of psoriatic dactylitis, which is the sausage digit. I'll go through this example very quickly. Okay, this is another finding that we can see in psoriatic arthritis, which is especially in the mutilans form, which is this pencil in cup deformity that we see here. This is a very aggressive arthritis, and patients with psoriatic arthritis can have that. And of course, we can find as well ankylosis. So this is the psoriatic arthritis mutilans form. This is only 5% of subjects develop such arthritis. Again, this pencil in cup feature in this form of psoriatic arthritis. Sacroiliitis can occur, especially in the spondylitic form of psoriatic arthritis. And very often we will see bilateral and asymmetric sacroiliitis, more often unilateral compared to ankylosing spondylitis. And what we see is marked sclerosis, like in this case, this is an unilateral sacroiliitis. With marked sclerosis, we see more sclerosis than we see in ankylosing spondylitis. And we see, on the other hand, less ankylosis in the sacroiliac joints than we see in ankylosing spondylitis. We're going to see as well syndesmophytes in the spine, but the characteristic here is that they are large and asymmetric syndesmophytes, which is typical from the axial involvement of psoriatic arthritis when we compare to patients with ankylosing spondylitis. I go through this very quickly. We have other forms. This is the worst of them, the rheumatoid form of psoriatic arthritis. I saw many females being treated by rheumatoid arthritis, and 5 years later, the arthritis, we see the cutaneous involvement of psoriasis. So this is a problem, and this may occur. So this is the worst form for rheumatologists. Isolated distal interphalangeal arthritis may occur, and isolated enthesopathies, especially in the lower limb. Extra-articular involvement may also occur in those cases. So just to finish, and these are a quick slide, this reactive arthritis, this was called Reiter syndrome. We don't call like this anymore. Affecting young adults, it's extremely rare, affecting especially males, and especially coming from the urogenital tract. The infectious agents, they often come from that tract. And up to 95%, they express the HLA-B27, which is good for the diagnosis. And sometimes the reactive arthritis may present with the classic triad of arthritis, urethritis, and conjunctivitis, which was defined as the Reiter syndrome. But we know that many of reactive arthritis doesn't fulfill the classic triad, but they should be treated just the same. So a bunch of microorganisms may be involved, as you can see here. I'm not going through detail in those. This can be both infectious or aseptic reactive arthritis. We never find the agent causing this. So more often presentation is the incomplete forms, as I told you, and it presents by asymmetric oligoarthritis of the lower limbs. So knee, ankle, metatarsophalangeal joints in up to 75% of cases. So the reactive arthritis, sorry I forgot to translate that one. So we don't see a lot of osteopenia. We see a lot of hyperostosis. We see large and asymmetric axial syndesmophytes. And we see unilateral and asymmetric sacroiliitis. So this is very similar to psoriatic arthritis, very similar. Those have very similar findings. So think about those two when we see those findings. But reactive arthritis is more frequent at the lower limbs, and psoriatic arthritis in the hands. So remember, upper limb psoriatic arthritis, lower limb reactive arthritis. Involvement of distal interphalangeal joint is rare, as well as the digital tufts. We see an example of large and asymmetric syndesmophyte here in a case of reactive arthritis. And this is another case that I want to show you of unilateral sacroiliitis in a subject with reactive arthritis. And to finish the presentation, enteropathic arthritis is associated with Crohn's disease and ulcerative colitis. We have other forms of intestinal involvement related to spondylathropathies, but those two pathologies are the main ones associated with arthritis. Appendicular involvement occurs in up to 20% with asymmetric oligoarthritis. We can find isolated enthesitis. You see, it's really repetitive what I'm talking. Those are very similar in terms of features. The problem is when we have the appendicular involvement in the subjects, the HLA-B27 is negative. However, when we have the axial involvement, the HLA-B27 will be positive in up to 75%. And this is helpful to perform the diagnosis. We can see isolated sacroiliitis in up to 18% of cases, symmetric, bilateral. We can see some ankylosis as well. So basically, the axial involvement of enteropathic arthritis, it's very similar to ankylosing spondylitis. So we just have to know if the subject has historic clinic history of bowel involvement, of Crema, or ulcerative colitis. One last example. So this is a 28-year-old man with ulcerative colitis. We can see here typical features of ulcerative colitis in the left colon, the descending colon. Here, just to show you, multiple ulcers and loss of morphology of the left colon, the descending colon. And this subject developed synovitis within the knee. And this was just when he had some activation of his ulcerative colitis. It happened in the same time. So this was easier to make the diagnosis because we knew the clinical history of the subject before. I will skip that one. And I'll come to the end of the presentation. Thank you so much.